Thank you for joining us today. The first question is about the temporal stability of the plaques. With virtual histology and OCT images, what is your perspectives on the temporal stability of the plaques? And also, are there any predictors for plaque stabilization?
Yes. We analyze using the virtual histology in the stable angina cohort, which include 99 patients, and then we have about 200 non-calipus lesions, and then we compare the baseline and 1 year later. And we see the lesion level comparison. And then what we found is actually the plaque changed a lot, even within 1 year. Most of the TICFA, half of the TICFA changed to thick-cap fibrillary, but thick-cap fibrillary stay as thick-cap, or many pathological intimate thickening change to TICFA or either thick-cap fibrillary. So they change a lot, but in general, they change to the more stable plaque phenotype. That's what we found in the stable angina patient. And we moved to the unstable angina patient using the Horizon MI cohort. And all patients has ST elevation MI, and we did VH-IBUS analysis in non-calculate as well. And then we compare the baseline and 30 months. And then what we found is, yes, they change a lot. There are a lot of dynamic change, but basically the baseline amount of the TICFA is almost half of the lesion, and then even more at the 1 year later. So even though most of the patient has very optimal medical therapy, but they have worse lesion scenario and then even worse. So that's big difference compared to the stable patient versus ST elevation MI patient. And we don't have the data using the OCT, but according to our other data, like such as Dr. Akasaka, what they found is compared to the OCT baseline follow-up, they see the change of the fibrous cap thickness. That's quite interesting. It's completely different, which we can see by VH-IBUS. And what they found is using the 9 months follow-up period compared to the baseline follow-up, they see the much thicker fibrous cap thickness in the region. And then what they found in terms of the predictor to see the difference is if the patient hypersensitivity CRP is getting better, they see much thicker fibrous cap at follow-up. And if the patient lipid profile getting better, the plaque burden evaluated by IBUS at the same time is getting better. So, however, this cohort is relatively small, but I do believe this is a very interesting observation as well as makes sense to consider pathophysiology. But those kind of things we can observe by VH-IBUS or OCT. Yes.
What do you think, what is the clinical implication of this observation?
Yeah. I think that we see many change even within 1 year. But we don't have the clinical implication of this cohort because everything is very small cohort. And if stabilize less myocardial infarction, if stabilize less mortality, that we should expect, but we have to think about how we can translate those kind of information into the clinical practice. And at this point, we don't have yet. But using this kind of serial evaluation, what we can use is, for example, I would confirm this drug in terms of the stabilization. And then using this drug, and then we see the baseline follow-up, and then we see the difference using the VH-IBUS, and then such as change of the phenotype or necrotic core amount, or by OCT, the change of the fibrous cap thickness. And if we confirm that drug effect using serial imaging modality, we expect that change translated to the clinical outcome. So yeah, still that's not clear enough, but that's a way which we should move forward using this kind of observation.
One of the other research subject is plaque distribution and composition between left main bifurcation and non-left main bifurcation. what is differences between the two, and what would be the clinical implication of the observation in terms of treatment strategy and PCI outcomes for bifurcation lesions?
We expect the left main bifurcation and other bifurcation is different because of if you compare the left main bifurcation stenting outcome in terms of the side branch compared to the non-left main bifurcation stenting outcome in terms of the side branch, you see better outcome in the non-left main bifurcation region in terms of side branch. But then that's the reason why we expect that's a difference. Mm-hmm. And also when you see the IVUS or other image in the regular clinical practice, we see more focal lesion in the ostial diagonal branch or something. That's compared to the left main. Mm-hmm. That's what the expectation. Mm-hmm. And we evaluate exactly same way which we did for the left main. We evaluate from the distal LAD to proximal LAD, and also distal diagonal branch to the proximal LAD, and then we compare how it looks like their longitudinal plaque distribution compared to the left main bifurcation. But the answer is quite similar. They are quite similar. And LAD always more, a main branch is always more, and side branch is less, but still the ostial diagonal branch has relatively diffuse and enough disease, which we didn't expect. In terms of the clinical, how this information can use for the PCI procedure, and if you consider what's happened after the stenting in the bifurcation, if you put the stent, crossover to the main branch, crossover to the side branch, we see either carina shift or plaque shift at the bifurcation. And then the ostium of the side branch will be compromised. How we can expect what kind of bifurcation can have this phenomenon? And if we compare the base pre and post IVUS, if the angle is less, we see more carina shift. And if we see the less plaque, we see more carina shift. In other words, if the region has more plaque at the ostial sac, we see more plaque shift. So original plaque distribution may affect of the mechanism what happened after the crossover stenting. So that's the one thing. And in general, we know compared to the left main bifurcation and the LAD diagonal bifurcation or the other side branch, and we know the angle is quite different. And the left main bifurcation is much wide angle and a lot of variation, but LAD diagonal bifurcation is less angle, also they have less variation. So using that kind of information, we expect most of the ostial compromise at the LAD diagonal branch can be carina shift rather than plaque shift compared to the left main bifurcation. So using everything together, the main difference is, I would like to say, the size of the vessel, and also we know the proximal side has more plaque, so longitudinal location, and also the angle compared to the main branch and side branch. So everything together, what we can expect is that what I said. Yeah, that's my understanding in terms of the difference compared to the left main bifurcation and the LAD to diagonal branch.
You had a lecture in the debate session with FFR.
Yeah.
So, do you think if the criteria based on the FFR over 0.80 would be safe for D4? If it is not enough, what do you consider to decide to treat or not treat?
My answer is, I believe yes. Yesterday I had to debate, so I said no, but in general I agree using the FFR over the 0.8 is okay to defer. But when you see the data very carefully in terms of what the evidence to prove that's decision making is actually there is a little bit weak. I mean, the data such as DEFER trial is a little bit old, was published like 2001, and half of the patient was treated by bare metal stent, And if you see the event, such as hard event, such as death or MI, the incidence is very low. So we see very low incidence in terms of the hard event, but still to consider the statistical power, it's a little bit difficult as evidence to show this is really true. And FEM trial is also true that we believe a lot and we were affected a lot by FEM trial, but that's also relatively old stent error. So most of the patient was treated by first generation stent. So we know the second generation stent is better in terms of the stent thrombosis, in terms of target region revascularization, or even peri-procedure MI. So including everything together, if we do exact same study using the second generation, the difference can be much less compared to the original FEM trial. So we are getting better in terms of the stent strategy or stent itself, and those kind of concept is changing a lot in terms of the how to decide. But still, in general, I believe bigger than 0.8 is okay. However, still we should have space to improve more. In the prospect trial, what we see is not only the lumen compromise, if the patient, if the lesion has bigger than 7% plaque burden, or the lesion has TICFA, the odds ratio compared to without, actually that is 11 times. So including the plaque burden or TICFA, this is truly plaque characteristic, not related to the lumen compromise. Using those data, we can identify the lesion which cause event 11 times compared to without. That's huge positive predictive value. We don't have the data using this information to prove in terms of the clinical outcome yet, but still we have the data. That's, I think, promising. But fortunately, the current using the optimal medical therapy, fortunately, the second myocardial infarction or target region revascularization, or of course the mortality is getting less and less. So to prove that's work, even the FFR is more than 0.8, but still if we found big plaque burden, big TICFA, we should stand now to prove that's phenomena in the current very good outcome generation. It's a little bit hard to prove, but that's still, I do believe we should have space to improve more beyond FFR more than 0.8.
Next question is about OCT. In the practical point of view, what do you think the clinical utility of OCT during the PCI? Because sometimes it is a little bit demanding to do OCT during the procedure.
Yes. First, we should think about when you want to see OCT. So you should have clear idea when we have the benefit to do OCT rather than IVAS or just angiographic guidance. So when my feeling is, let's say the patient has unstable symptom, and then you take the angio, but you don't see very clear unstable lesion by angio. This is like 50% stenosis. This is also 50% stenosis. We are not clear what's going on. Those cases, such as we don't know where the culprit is, that's a good way to do the OCT. And then you do the OCT, and you see the very fibrotic tissue without anything in the first region, and then you see the plaque rupture with some subclinical thrombus in the second region. We clearly understand that's a culprit. And or if you can understand, this patient has coronary artery related symptom, not others. You can prove using the OCT. So one good situation is you don't know what's going on in this patient, and you would understand in terms of the pathophysiology, OCT could benefit more than IVAS, and of course rather than just angiography. That's one thing. And the second thing is, I think the chronic stent evaluation is very meaningful because OCT can detect the stent slot is very clearly. Let's say we have very calcified lesion and then like 2 layers stent slot, and then do IVAS is very difficult. We cannot see which is stent slot, which is calcium, and what's going on. But when you see the OCT, you see very clear stent slot and can be delineated with can differentiate with the calcified plaque behind. And then you understand this is very under expansion, too rare, because of the calcified region. So those kind of very complex chronic stent failure, which we don't know what's going on, and difficult to understand by IVUS, those situations, OCT is very meaningful than other things. And of course, we know the neoatherosclerosis is important, and those plaque variation could be much better using by OCT. And of course, still the data is not enough, but how we can predict the late stent thrombosis. We would like to see the stent coverage. We would like to see the neoatherosclerosis and developing some plaque rupture inside of the stent, or we would like to see the subclinical thrombus, which was reported as 20% as incidence by other, like such as angioscopy or OCT. So including everything together, chronic stent evaluation, that's very meaningful to the OCT rather than IVUS or other things. So in terms of the OCT guided stenting, still we are not very clear, because we are not used to use OCT as guidance, because we cannot see EM very clearly. There is some small randomized study from Japan. They randomized 35 OCT guided and 35 IVUS guided. And then they did both way, and then finally they document each modality. And then what they found is minimum stent area by OCT guided was 1 square millimeter less compared to IVUS guided. So that's just because of they cannot use bigger balloon, because they are not very sure what the size of the vessel is. But still, I do believe we are on the learning curve. As long as we understand well, compared to the reference, how we should choose the stent as safe, maybe that can be improved in the near future. But just using the OCT and replace IVUS, still we have to think about what's the best way, and that's what I think. Yeah.
Thank you for your comprehensive and careful answers today.